Hello and welcome. I'm Don Renfrew, and for the next hour or so, I'm going to be speaking on imaging of joint complaints. I'm a member of Radiology Associates of the Fox Valley, which is a 30-plus radiology group that covers upper central Wisconsin. And before joining Radiology Associates, I've been on staff as a musculoskeletal radiologist at the University of Iowa hospitals and clinics, and also at Rush Presbyterian St. Luke's Hospital in Chicago. At present, I work at Door County Memorial Hospital, which is a small community hospital in rural Wisconsin. It's where the Red Star is located here. And it's a 25-bed critical access facility. It's about 50 miles from the closest other hospital. I am also the director of Grand Rounds, a monthly meeting where we talk about tumors or interesting cases. And as part of presenting material for those recurring conferences, it became clear to me that the referring clinicians often needed to have some pretty specific direction or needed some additional advice in general terms about what imaging procedure to obtain for a given clinical complaint. Primary care practitioners in general have various degrees of training as to which radiology study to order and what those radiology studies can do and how beneficial they are for the care of their patients. And so these talks are basically made to try to provide information to primary care practitioners, and that would include family medicine physicians, physician's assistants, nurse practitioners, emergency medicine physicians who do see patients on a primary care basis within the emergency room, internal medicine physicians, any healthcare provider, particularly those specialists, for example, operating outside their usual field of expertise, who may need to order a radiographic study. So that's what this talk is all about. As a practicing clinician, you have a lot of options for evaluating joint complaints: plain films, CT, MR, nuclear medicine, ultrasound. There's just a lot of different ways to image joint complaints. At the same time, as a cost-conscious clinician who is also attuned to trying to do the very best you can for your patient's good health, you want to order the right test the first time, every time. You don't want to waste time or energy or radiation or patient concern by obtaining the wrong test or too many tests. So with that in mind, what I'm going to do today is review imaging of joint complaints. Now these lectures, this lecture in particular and the lectures that I give in general, are set up so that I'm trying to convey 2 or 3 major points that will stick with you over the long haul of a several-month period. I will say that this particular lecture is kind of challenging to put into that format, and here's why. You can make a couple of generalizations about imaging of the musculoskeletal system, but a lot of the recommendations about imaging the musculoskeletal system have to do with the joint concerned. So the general recommendations that apply to shoulder, elbow, wrist, hand, hip, etc., that apply across all those joints are kind of weak and diffuse, and the real recommendations come within each of the different joint areas, because the diseases are different that produce symptoms, and the complaints are different that bring the patient to you as a clinician. Therefore, the red slides here are the important points that I want you to take home, but there's also a lot of additional information kind of diffused through the last part of this lecture. The other thing is there's a lot of material in this lecture. There's a ton of different exams and a ton of different examples. And the reason that I'm bringing you all this is that it's an important topic. It's a topic that I've spent a lot of time, energy, and effort thinking about and studying, and I want to try to convey some of that to you here in the next hour or so. So as far as the major points of this talk, there are actually quite few. There are 2. The first one is that monoarthropathy can be the precursor of polyarthropathy. Now, virtually any arthritis can initially present at a single joint and as a single joint abnormality, and pain in any given joint can represent the first manifestation of polyarthritis. Now, I give a separate lecture on the topic of polyarthritis, and I'm not going to review all the points in the lecture, that lecture here, but I do want to say that you have to keep in mind that monoarthropathy can represent the first part of polyarthropathy. So it can be in early rheumatoid arthritis, a young woman, a 40-year-old woman may come in with wrist pain, and you have to be sort of on the alert for the fact that that may simply be the first joint in her that's manifesting as a polyarthropathy. Psoriatic arthritis can present as monoarthropathy prior to the development of skin lesions. Now, as I noted in that other lecture, however, plain films don't really do you a whole lot of good in many of those cases, even though they will be obtained. They'll often be either negative or non-specifically abnormal. Now, when should you be suspicious that the monoarthropathy you're seeing is actually the first manifestation of a polyarthropathy? Well, in the absence of trauma, a history and physical exam will usually help determine whether there are any additional features like a rash or a fever or weight loss, which suggests a systemic process that may be a manifestation of, that may be manifesting as a monoarthropathy. So other than trauma, infection, especially gonococcal and crystal arthropathy, usually gout and CPPD, are the main causes of monoarthropathy. So you want to usually aspirate the joint if there's an effusion, and then analyze that fluid. That's the key to making the diagnosis in most cases. Imaging usually doesn't add a lot of information in these cases. But again, monoarthropathy, keep in the back of your mind, is a single joint pain that this patient is having actually part of a more widespread process. Okay, so that being said, the other major point of this talk, and again, you know, this is kind of a diffuse point, but imaging, you have to kind of tailor it to the joint. In general, you're usually going to start out with a plain film because that is, it's tradition and convention and whatever else. After that, you can figure out whether you want to do CT, MR, arthrography, or nuclear medicine studies on the basis of either your own knowledge, background knowledge that I'm going to try to provide in this lecture, or on the basis of consultation with the radiologist, or by relying on what the rheumatologist or orthopedic surgeon says to do in a particular case. So plain films are the first step. They're usually readily available, they're relatively cheap, they're pretty straightforward to interpret. It's hard to generalize across the different joints, like I say. The next probably 50 minutes I'm going to talk about various conditions and specific joints through the body that can cause symptoms in those joints, and we're going to go from top to bottom. Spine pain I talk about in another lecture. So let's start out kind of at the top. Shoulder pain. And again, pain in general you can usually divide into acute post-traumatic, chronic post-traumatic, or just chronic. Acute non-post-traumatic is sort of that monoarthropathy that I just mentioned. So in all these cases, you know, think about that first. So how about acute post-traumatic shoulder pain? Well, plain film is usually your first step. You're going to look for fractures and dislocations. If the plain film exam shows a complex fracture that needs surgical fixation, CT can be done to evaluate the exact anatomy of the fracture. But the decision to order that CT is usually left to the orthopedic surgeon. It's them that have to figure out whether they're going to have to instrument, how they're going to instrument, where the screws and nuts and bolts and plates and all that stuff is going to go. And therefore, you know, you usually leave ordering the CT to them. If the plain film's negative, but you really think that there's some sort of bony or significant soft tissue abnormality, you probably want to order an MR study. MR is going to show you both occult fractures and also show you significant soft tissue injury. Okay, so let's go through some examples here. This is acute post-traumatic shoulder pain, looking for fracture. This young man had trauma, and you see an acute fracture of the humeral head, here where the black arrow is. How about dislocation? Well, dislocations are usually clinically pretty obvious, but you know, you almost always get a plain film to document the extent of dislocation and whether there's an associated fracture, whether it's wise to try to reduce versus consult orthopedic surgery, whatever. This young man had trauma. He had an acutely dislocated glenohumeral head with the typical inferomedial displacement. The humeral head can also go backwards and up, either backwards or up or down. There's different fanciful terms like luxatio erecti for the position of the humeral head after that happens, and there's certain circumstances where you'll see that, such as electrocution, but those are all the atypical ones. The one important thing to think about is that you need some sort of axillary view of the humeral head to see some of those other dislocations. A straight posterior dislocation could be devilishly difficult to diagnose on a frontal film. So that's something to keep in mind when diagnosing shoulder dislocations. Here the arrow shows you the anterior-inferior displacement of the humeral head relative to the glenoid. All right, as I said before, complex fractures can require additional evaluation, usually at the behest of the orthopedic surgeon. Here's a 65-year-old woman that had pain following trauma. Your AP plain film shows a dent in the superolateral humeral head there by the arrow. And the axial plain film shows discontinuity of the glenoid and an immediately displaced bone fragment, which is also seen on the AP view with the black arrow in A. A little harder to see and harder to pick up there. Here's a CT done for further evaluation of that fracture, and the axial CT study at the level of the upper glenohumeral joint shows you indentation of the humeral head, the Hill-Sachs deformity, and the axial CT study in the lower glenohumeral joint shows fracture along the anterior-inferior glenoid rim with a medially displaced bone fragment. The imaging features are characteristic of dislocation and fracture. That glenoid rim fracture has been called a bony Bankart, which is kind of paradoxic in the sense that Bankart's original description of the lesion that occurred with recurrent dislocations of the shoulder specifically said that it wasn't a bony lesion, and it was talking only about the soft tissue component of that anterior-inferior dislocation injury. But some people do, you may hear the term bony Bankart lesion to describe the glenoid rim fracture. So here's a composite of the plain films and CT in this patient with anterior-inferior dislocation and resulting fractures. And the CT was ordered to better evaluate fracture alignment, position, displacement, surgical planning. Now, when you have a negative plain film, and you're really thinking, wow, this patient has to have a fracture of some sort, he's just too tender, just too sore, or if you think, oh, this patient's really painful, maybe they have a soft tissue injury, MR is usually your study of choice. The MR can show you occult fractures and significant soft tissue injury. Here's a 33-year-old man that had a fall on the ice, and the plain film shoulder the fracture, or the shoulder with the patient's shoulder internal rotation fails to show any definite fracture. With external rotation, there may be a subtle lucency there at the arrow suggesting a fracture, but it's hard to say for sure on the plain film. Here's MR pictures here in Mark C and D. T1 weighted image on our left shows you a black arrow located at the arrow of the so-called bone marrow edema pattern or contusion pattern there in the humeral head, the base of the tuberosity. D is a T2 weighted image showing striking bone marrow edema in the same location. So this is certainly a contusion, and you know, you can look at the line on there and say, well, this is actually at least a trabecular fracture. It probably extends to the cortex. So this is, you know, kind of straightforward fracture, which is hard to see on the plain films. So here's a composite again. The point being here, you got plain films which are equivocal or negative. You got severe pain. You get a shoulder MR. It shows you the extent of the disease process, the extent of the fracture. Here's another case of a 64-year-old woman who had acute shoulder pain after an injury on the plain film, and on the MR study, this is a coronal oblique fat suppressed T2. This shows you a full thickness rotator cuff tear, and it also shows you fluid along the normal course of the tendon deep to the deltoid muscle and superficial to the humeral head where the arrow is. Here's a composite picture showing you her rotator cuff tear, the C and D show you some additional, this is a sagittal oblique and then another deeper sagittal oblique showing you abnormal fluid covering the humeral head and extending up to the acromion, indicating a full thickness rotator cuff tear with retraction of the torn cuff margins. And then the more medially located coronal oblique shows you abnormal signal within the muscle belly compatible with tearing of muscle as the tear extends from the cuff margin distally into the more proximal muscle belly. All right, so that's acute post-traumatic. What about chronic pain, chronic shoulder pain? Well, it's good for a lot of things. You want to use plain films first, of course, and it's going to show you such entities as calcific tendinitis, seen here at the location of the arrow, where there's abnormal calcium deposition of the distal supraspinatus tendon in part of the rotator cuff. It can also show you chondrocalcinosis, a bit more subtle, on this picture with the white arrow, indicating the subtle chondrocalcinosis along the humeral head. There is, of course, severe degenerative change of the glenohumeral joint in this patient as well. Here, we can see degenerative change with a malformed humeral head in a patient who had a remote injury. The remote injury caused a number of problems, including damage of the articular cartilage directly, and then incongruous articular cartilage surfaces, which lead to early degenerative change, or changes earlier than you would otherwise get them. And plain films can show you degenerative changes of any joint, including the shoulder joint. Note that since your shoulder isn't a weight-bearing joint, it's generally held that, at least in patients that aren't paraplegic or amputees and use their shoulders as weight-bearing joints, typically, if you see significant osteoarthritis in the shoulder joint, you should probably think somewhere along the road of processes provoking that early degenerative change, such as a fracture, as we just saw in this case, repeated hemorrhages into the joint, hemophilia, other processes leading to repeated hemorrhages because blood and joint cartilage don't get along. And then crystal deposition, like CPPD, crystal deposition disease, if you've had that repeatedly. Any other cause of destruction of the cartilage, an inflammatory arthropathy or infection, which has resulted in destroyed cartilage, and then led to the development of secondary osteoarthritis. So there's things to think about if you see bad osteoarthritis in a shoulder joint. There's usually some underlying process there. It's usually not just an idiopathic osteoarthritis. All right. Now, if you have chronic shoulder pain, you have the plain film, and it doesn't really tell you all you need to know. The next study is usually going to be MR. In younger patients, especially where the athletes, especially young athletes, where shoulder instability is an issue from throwing athletes, your MR, you might even think about just starting out with an MR arthrogram, because you're looking for labral tears, and they're a lot easier to identify and assess if you introduce contrast material into the shoulder joint. Now, for your older patients, MR done without contrast material is usually adequate. And usually you're looking basically for a big rotator cuff tear. Sometimes pinhole tears can escape detection on a standard MR, and so some authors do advocate giving everybody that goes through a shoulder MR intra-articular contrast injection. And opinion on that varies. Now, in this example, we have a 19-year-old who'd had repeated shoulder dislocations in the MR arthrogram. The white stuff in the joint here is the arthrogram contrast material. It shows a large filling defect along the inferior recess from a chronically torn labrum. So that's the deal on chronic pain in younger patients. And chronic pain in older patients, of course, you're looking for this disease or a rotator cuff tear. This is a full thickness rotator cuff tear in a 57-year-old man who'd had chronic pain and shoulder weakness. Your coronal oblique fat suppressed T2-weighted images here show a full thickness defect of the supraspinatus tendon, and it shows your retraction of those torn tendon margins. Now, as noted on this slide, it's important not to overemphasize the relevance of a full thickness rotator cuff tear in an older patient. So as you see here, this study found that a lot of patients over the age of 60 will have full thickness tears, you may not even call them patients. You may just call them asymptomatic subjects. So if you have somebody that's 72 and has a sore shoulder or painful shoulder, and you find a full thickness rotator cuff tear, that may or may not be the cause of their pain. I mean, usually it is held to be the cause of their pain, but again, studies like this one make you realize that not all rotator cuff tears are symptomatic. So you have to ask yourself that question. Another scenario to think about is the shoulder evaluation in patients that have had a prior rotator cuff repair. When you do the repair and the capsulography and the chromioplasty and all that stuff, it can incite pain in the shoulder, and then you got the rehab, you throw that in. You got to figure out whether, when the patient comes in 6 months or 8 months or a year down the line, whether it's all post-op or whether they got better for a while then worse, if they were better for a while through therapy and then therapy one day made them worse. Try to figure out in your mind, well, is it a tear/re-tear phenomena, or is it just tear, repair, and healing that's going on? Usually the method of choice for evaluating that issue is to do an MR arthrogram, or at least an MR. Now, these repairs of the rotator cuff aren't necessarily watertight. I mean, the original joint, as issued from the factory under warranty, is going to be watertight. I mean, your rotator cuff should be watertight, especially if you're 23 years old or 31 years old. But after repair, may not be. You may have an injection of the glenohumeral joint going through the rotator cuff into the subacromial deltoid recess, or bursa. But any large gap in the repaired cuff is probably a failure of the repair. This 61-year-old had several years of pain relief after a repair, and then he had recurrence of symptoms. And you can see that he's had a repair, tear, or a tear, repair, re-tear. And you know, when the gap is real large and the symptoms are widely separated from the time of initial repair and the patient has had good recovery in the interim, it's pretty straightforward. A lot of times it's not so straightforward. The patient's 4 months out, never to get all that much better. You got a little gap in the repair, so you know, it's those patients are challenging. So when the going gets tough, we choose to change joints from the shoulder to the elbow. How about elbow pain? Well, in patients with acute elbow pain after trauma, again, plain films first, you're going to look for cortical discontinuity, also a displaced fat pad, which is an indication of a joint diffusion, and in the setting of acute trauma, it's usually a secondary finding indicating a non-displaced radial head fracture. If the plain films don't show any fracture or dislocation, MR can be helpful, especially if there are features of a biceps tendon rupture or some other significant musculotendinous abnormality. So let's look at a couple of examples. Here's a 2-view plain film in a 51-year-old woman who had pain following trauma, fall on an outstretched arm, the typical history. Lateral plain film shows displacement of the fat pad from the anterior aspect of the distal humerus. Your oblique film here shows a subtle fracture through the radial neck. And elbow effusions after trauma, again, are usually secondary to hemorrhage in the joint from a fracture. So the marrow and the hemorrhage out of the bone come into the joint space. All right, so if the plain films are negative, what are you going to do? Let's try an MR. Here we got an MR with some labels on it, including this cross-sectional image through the distal humerus or elbow joint. Actually, it's going to be the elbow because you got the radius ulna labeled there. Biceps tendon shows up there. This is a patient who had pain following a lifting injury. Plain films were normal. I'm not going to show those here, but they were normal. Here are your white arrows on the biceps tendon in A and B. And note that the biceps tendon changes caliber significantly from A to B. Now we got A, B, and C. And you can see biceps tendon, no biceps tendon. So this was a distal biceps tendon tear, and you can probably see it on this composite a little better by appreciating all three, and then the sagittal view where there's a discontinuous biceps tendon. Of course, the full MR exam is going to include lots and lots of pictures, slicing all the way through this in all three different directions, and showing you all the muscle edema and all those other findings that can help diagnose a biceps tendon tear. Also, biceps tendon tears are typically, fairly clinically obvious with a balled up Popeye muscle in the arm and no biceps tendon palpable distally. A lot of times these patients are sent for imaging for confirmation of what's already a pretty highly suspected injury, or for measurement of that gap, or to see what kind of muscle you have. And not all of these, it's not a life-threatening thing to have a torn biceps tendon. A lot of people walk around with one. You can get it repaired for either cosmetic or functional reasons, although surprisingly you don't lose a whole bunch of power for biceps curls after losing the biceps. There's still a brachialis muscle after all. Anyway, just as in the interest of thoroughness, and because this was an interesting case, I threw it in here. There's a pronator teres tear. You can see muscle tears on MR quite well. You can see muscle hemorrhage quite well. There's a grading system for muscle tears, and basically you look at minimal tears with a little bit of bleeding, a little bit of edema, kind of moderate tears with more torn tissue, to severe tears where they're full thickness or near full thickness or retracted. And again, the decision whether to intervene and try to repair a torn tendon or muscle is kind of up to the orthopedic surgeon. In some cases there's merit in doing that. In others, especially all these partial thickness tears, they'll usually just repair on their own. And as long as you can confirm that there's basically continuity of the muscle and tendon without a full thickness tendon tear and retraction, there's not much you're going to do other than time and supportive measures to get that to heal anyway. All right. So those are the acute injuries in the elbow. What about chronic elbow pain? Imaging is usually not helpful. Exceptions can include evaluating your throwing athlete, shoulder, labral tears, subluxation. You're worried about elbow, medial collateral ligament tears typically. You're looking at radial collateral ligament tears. Here's an 18-year-old male pitcher with ulnar-sided elbow pain. So now we're looking for whether the ulnar collateral ligament is or isn't intact. Usually that's best established by an MR arthrogram. The picture on the left just shows you where the contrast went in, and it shows you contrast in the joint. And then on the right, it shows you intact ulnar collateral ligament. It's important to have that. I mean, otherwise you may need surgery to repair that if you've got ligamentous laxity or rupture on that side. And MR is a good imaging technique to kind of sort that out. So those are pitching injuries, athletic injuries. MR arthrograms, probably your study of choice. Another thing that can cause chronic elbow pain, sometimes you can see loose bodies within the joint, as on this plain film exam. Sometimes those osteocartilaginous fragments are mostly cartilage or all cartilage. It can be harder to see, in which case MR can be helpful, especially if there's a joint effusion, because you see it as a filling defect in the joint effusion pocket. As a 50-year-old woman with this picture is a 54-year-old man with elbow pain, and image A has an arrow on the loose body anterior to the humerus, and image B is an MR sagittal, sort of correlative image with an arrow on the loose body in fluid. All right. What other kinds of chronic elbow pain causes are there? Well, there's ulnar neuritis. It's usually a clinical diagnosis. This is a 50-year-old woman with cubital tunnel syndrome. The axial T2-weighted image demonstrates increased signal at the location of the ulnar nerve. So that's ulnar neuritis. Now, one other entity to talk about, which is a clinical diagnosis, is common extensor and flexor tendon abnormalities. Painful common tendon origins are called epicondylitis. That's a misnomer because the epicondyle is part of the humerus and it's not inflamed. It's not this tendon origin, this common tendon origin. Now, if it's the lateral extensor tendon origin, they usually call it tennis elbow, backhand, or if it's on the medial side, it's often called golfer's elbow, forearm, or striking the golf ball. And MR is going to show you abnormal signal in patients with chronic elbow pain. It's usually not all that helpful unless you're looking for full versus partial thickness tear to kind of grade or confirm the injury. So that gets us out of the elbow and onto the wrist. You can tell there's a progression here, so kind of march along. And in all these locations, plain films, especially for trauma, is going to be your initial study of choice. Wrist trauma is pretty frequent. Again, falling outstretched arm is going to be your typical history. And fractures can occur in the distal radius and the carpal bones, and they can occur obviously fracture dislocations. And again, a lot of these are going to be referred directly to orthopedic surgeon, particularly when they're severe, intra-articular, associated with dislocation of the carpus and so forth. Minimally displaced fractures can be treated with splinting, and sometimes are handled by primary care providers, but in the US anyway, a lot of this stuff ends up going to the orthopedic surgeon. So here's a 48-year-old woman who had wrist pain after trauma. The lateral exam better shows the lucency with a cortical interruption along the distal dorsal radius. Here's another fracture. This is a little bit of an unusual fracture. It's an 18-year-old man who had pain after a fall on an outstretched arm. And you can see the subtle lucency through the pisiform bone, that little bitty P-shaped or pisiform bone in the carpus. The lateral exam shows you the fracture as well. This exam, on the other hand, is a fracture dislocation pattern called perilunate dislocation. This was occurred after trauma as well. You see abnormal alignment of the lunate there on the AP, and the lateral exam shows anterior dislocation of the lunate. It's been rotated 90 degrees from its normal orientation. Those are bad injuries to have. Now, fractures of the scaphoid are pretty common because this bone spans both the proximal and distal carpal rows. With respect to scaphoid fractures, the plain films can be negative in a fair number of cases, and usually the motto is to follow those in 10 to 14 days after immobilization. Alternately, you can get an immediate MR. Scaphoid fractures through the proximal aspect can undergo non-union and avascular necrosis because of the vascular supply coming in distally, and the more proximal the fractures in the scaphoid, the more likely it is to cut off that vascular supply and lead to avascular necrosis. Like other joint injuries, when there's a high suspicion of fracture or soft tissue injury and negative plain films, you can get either a C2 or an MR for further evaluation. MR can demonstrate soft tissue injuries that can cause pain. So here we have a 79-year-old woman who had pain after trauma. She had rheumatoid arthritis, and the plain films show chronic changes secondary to rheumatoid arthritis, but really don't show you an obvious fracture on the frontal. On the lateral, you get the feeling there's a possible interruption of the distal radial cortex there. And on the CT study, the axial and sagittal reconstruction views demonstrate the fracture line, and it is intra-articular, although not severely displaced. So again, CT showing a fracture pretty easily, which was hard to see on plain films, as seen on this composite view here. Other injuries, of course, here's a bone contusion and tenosynovitis, or inflammation of the tendon sheath in the adductor pollicis longus tendon in a 56-year-old. She'd had direct trauma to the lateral aspect of her wrist. Her plain films, which I'm not going to show you, are negative. The axial fat-suppressed T2-weighted image showed increased signal intensity in the distal radius, compatible with a bone contusion, and then you see some fluid along the adductor pollicis longus tendon, compatible with post-traumatic tenosynovitis. So MR shows you injuries that you're not seeing on the plain film. Now, was it absolutely critical or life-threatening that in this particular case, this diagnosis be made? Probably not. I mean, it's going to be supportive care in either case. I mean, what decision would you be thinking about? Well, the main decision is, do you have surgical intervention or not? And in those cases where there's an occult fracture, it may be a consideration. If there's a full thickness tendon tear, may be a consideration. And there is another one I'll be coming up here with in a minute. So wrist pain, that's the acute issues. And again, just like the other places, you do the plain films first, then you do the cross-sectional imaging. How about chronic wrist pain? Well, chronic wrist pain, plain films can be helpful. Here's a 69-year-old with thumb carpal metacarpal joint osteoarthritis. You've got an oblique plain film that shows joint space narrowing and osteophytic spurring here at the arrows. So in this instance, it was good to have the plain film, showed you the cause of the chronic pain. They can also show you variations in carpal anatomy, like the so-called ulnar variants, ulnar plus variant, ulnar minus variant. If there's an ulnar plus variant, then the ulna is longer than the radius, and that can be associated with what's called ulnar abutment. And the ulnar minus variant, the ulna is shorter than the radius, of course, and that can be associated with avascular necrosis of the lunate. Here's an ulnar minus variant, an arthritis in this case, rather than the avascular necrosis. This woman was 62, and she'd had a lot of distal wrist pain, distal radial ulnar pain. Plain films are also sometimes helpful for secondary signs of de Quervain's tenosynovitis that occurs through the short extensor and adductor tendons of the thumb. Here you see some secondary changes of the underlying bone from chronic inflammation of those tendons here along the radial styloid. Again, chronic wrist pain. Another cause of chronic wrist pain, degenerative changes from a so-called SLAC or scapholunate advanced collapse abnormality. This is a 67-year-old male with chronic wrist pain. You've got widening of the scapholunate interval at the white arrows, and then proximal migration of the capitate with elimination of the joint between the capitate and lunate there at the black arrow, along with some degenerative changes between the scaphoid and radius. How about chronic post-traumatic wrist pain? MR can show you radiographically occult ganglia. Here is a 16-year-old volleyball player with chronic wrist pain, and you see this lump of abnormal tissue along the dorsum of the wrist, which was a ganglion. MR is often supplemented by arthrography to demonstrate the triangular fibrocartilage and interosseous ligament tears. Like shoulder rotator cuff tears, the significance of TFC tears and interosseous ligament tears in the middle-aged people is questionable. Here's a ligament tear in a 52-year-old man with chronic ulnar-sided wrist pain. You see on the image on the left, early on in the injection, some contrast in the radiocarpal joint. In a later picture taken on the right, you see the black arrow with contrast in the midcarpal compartment, which is abnormal. A white arrow showing you how that contrast got there, which was through a torn lunatotriquetral interosseous ligament. Again, you know, those ligaments may not be watertight in 50 to 60-year-old patients, even if they're asymptomatic. So you have to interpret that finding with caution. How about hand pain? Well, it's familiar refrain. Plain films first. You're looking for dislocation, fracture, foreign bodies, some combination of abnormalities. Typical Salter-Harris type 2 fracture through the base of a small finger, proximal phalanx, in an 8-year-old here at the arrow. There are a couple of acute thumb injuries, which we'll go over briefly. There's a Gamekeeper's thumb and there's a Stenner lesion. The ulnar collateral ligament of the thumb is an important stabilizer of the thumb MCP. Chronic repetitive injury said to occur from wringing the necks of game birds, you know, this. That can cause damage to that ligament. You can also get it from post-traumatic injury acutely. It's usually against a ski pole. You know, you're going to pull the ligament apart by ramming it, or by holding the ski pole and then having the ski pole get stuck. And you can have either a sprain or a rupture of this ligament. Now, if the ligament's ruptured but non-displaced, it can heal as long as it's held in position. And this is a classic Gamekeeper's thumb. There's an adductor aponeurosis, which is over the superficial aspect of the metacarpophalangeal joint ulnar collateral ligament. And if that aponeurosis is also torn, and the ulnar collateral ligament is displaced superficial to the aponeurosis, and the injury is said to be a Stenner lesion. And that often or usually requires operative intervention. You want to refer those to the orthopedic surgeon. And probably any of these ulnar collateral ligament injuries, you might want to think about hand surgeon or orthopedic surgeon, because failure to diagnose these can lead to disabling, debilitating, and painful laxity of that joint. And of course, that joint is used all the time for everything, so you don't want to miss a lesion of that. Here's a picture of that. It's a 16-year-old male. He had a football injury, and the AP exam shows some abnormal fragments of bone. The coronal B is the coronal fast suppressed proton density MR, and that shows some discontinuity of the ulnar collateral ligament. And then on the proton density image, he's got increased signal with a contusion along the proximal ulnar aspect of the proximal phalanx at the arrow there. And then in D, he's got the overlying aponeurosis is intact. So this is Gamekeeper's rather than the worst Stenner lesion. Moving along, chronic hand pain. You're going to get back to arthropathy right away here. Is it monoarthropathy? Is it polyarthropathy? Is it really, something we need imaging for? Because a lot of times, again, the imaging may not help you much. If only one joint's involved, you should think in terms of MCP joint strain or arthritis. Plain films can distinguish those two. And then gout, you can usually find gout on a plain film, especially if it's been there a while. MR is rarely used unless there's a suspicion for tenosynovitis or a retained foreign body. This is an example of a 59-year-old woman with an acute thumb pain. Didn't have any injury. The AP showed calcified tophus in this patient who ended up having gout. So we're out of the upper extremity and about 20 minutes left here. Hip pain. How about acute post-traumatic hip pain? Well, x-rays are your exam of choice, just like any of these other locations, and you're looking for fracture. Here's a 75-year-old with pain following trauma, a very typical picture of a femoral neck fracture. Straightforward diagnosis, orthopedic surgical case, usually gets fixed. If there's bad arthritis in the hip anyway, they'll just put in a prosthesis, otherwise they'll pin the hip. There are different devices, and I'm not going to go into all those here that they use for that, and that evolves through time, of course. Now, what about those cases where the patient had a fall, they've got hip pain, they can't bear weight, you know it's fractured, you're really highly suspicious it's fractured, the plain films don't show the fracture. You can do CT or MR, and I'm telling you, CT can miss fractures. MR is more sensitive to subtle fractures, and it can also detect muscle tears that you're not going to see on plain film. So the choice is if the patient can do it, probably in MR, and then you've got a scanner. Here's a 38-year-old. This patient actually had an MVA and had some other injuries, and instead of going through the MR, she went to CT, and CT showed this subtle fracture of the anteracetabular wall, which was really impossible to see on the plain film, but you can see it there at the arrow on the B component of this. Here's another patient. This is a 94-year-old male. The plain film really can't see the fracture much. Here's the MR, T1-weighted coronal image in the B image here. The arrow shows you the fracture through the femoral neck, extending up to the femoral head. Now, this case is a 75-year-old woman who had chronic hip pain, and the STIR images show you increased signal in the left gluteus medius muscle compatible with a muscle tear. That kind of brings us into chronic pain issues. Again, x-ray is usually going to be your first imaging choice, and what you're looking for there are things like osteoarthritis, CPPD, gout. Let's see some examples. Osteoarthritis here of the left hip, joint narrowing, osteophytic spurring, the typical findings you'll see in any joint with osteoarthritis. Gout, kind of an interesting case where I've actually done therapeutic hip injection with an arthrogram, and you can see that big hole in the supraacetabular pelvis is actually an erosion / cyst with an overhanging edge there with the black arrow, and the contrast actually leaves the joint, goes up and settles in along that lesion. Plain films can demonstrate some processes which usually trigger further evaluation, like rapidly destructive osteoarthritis. Here you see images obtained over a 6-month interval with joint narrowing on the one on the left, marked A, more joint narrowing, marked progression of joint narrowing with persistent pain. The MR shows you tremendous edema in the femoral neck and head, and in the acetabulum on the other side. This was a case of so-called the rapidly destructive osteoarthropathy. Composite picture again showing you more of the same thing. Chronic hip pain and plain films show you osteonecrosis or avascular necrosis. Here the plain films actually show sclerosis, increased density in the femoral heads. Much more dramatic, conspicuous, interesting picture on coronal T1 weighted MR with femoral head showing markedly abnormal signal where the arrows are there, along with that typical mixed signal intensity at the interface, and abnormal signal in both heads. Stir images, a little bit of fluid in the heads again, and then here's the composite of all three. If the plain films are unremarkable in patients with chronic hip pain, MR can show you osteoarthritis and joint narrowing and articular cartilage loss that you won't see on plain films. It can show you avascular necrosis, which is either subtle or it's hard to see on plain films. In patients with an acetabular or labral tear, they'll have symptoms of clicking or locking, and MR arthrography can be helpful to evaluate internal structures. Here's a case where the plain film didn't show much. It's a 50-year-old, and she had joint pain. Here on the MR, she has cartilage loss and abnormal marrow signal adjacent to the joint, typical for osteoarthritis. The composite picture shows you some additional sequences on the MR, including the T2 weighted sequence and not only coronal oblique, but a sagittal oblique showing you a subchondral marrow signal in the hip. All abnormal. So, now, in general, you're going to see this more in the lower extremity than the upper extremity because of the frequency with which prostheses are performed, but basically, patients with prosthesis and after fracture fixation, usually they'll go undergo X-ray exam to look for dislocation and any hardware complication, and also dystrophic calcification. Usually those films are going to be ordered at 1 and 3 and 5 years, and then every 5 years by the operating orthopedic surgeon. Painful prostheses, which don't have any plain film abnormalities, but when you're thinking infection, usually need to be aspirated. If you do imaging, your best idea, or best course is probably to perform nuclear medicine bone scans with indium-labeled white cells, and the combination of indium-labeled white cells and bones imaging can distinguish post-op changes from loosening and infection. Here's kind of an obvious case of a prosthesis dislocation on the left, which has been relocated on the right. Here's a more subtle and interesting complication. The film on the left, marked A, shows you an initial placement of this helical blade plate with interlocking medullary rod. That blade plate that goes up into the femoral head and neck should back out with weight bearing and allow the fragments, fracture fragments to settle into each other and heal better. But it was not allowed to because it had slipped underneath the cortical margin of the fractured femur. So instead of backing out and allowing the fracture fragments to settle, the screws cut out of the femoral head. And that's not good because once you get inside the joint, you've got those bad things like joint hemorrhage, articular cartilage deformity of the congruent articular cartilage surfaces, and secondary degenerative change, as well as pain. Unusual complication here. Another complication that you can look for is heterotopic ossification. When it's in this kind of a position, it's often not particularly painful. If it gets to be a greater amount and is more around the joint itself, closer to the articular margin or along the neck of the femur, it can sometimes block motion of the joint. So, prostheses in general, plain film examination first. MR and CT can be done. It's problematic because there's artifact created by the prosthesis itself. So that gets dicey. Knee pain, acute post-traumatic knee pain. Again, there's a ton of examples I'm trying to show. I'm going to get through all these. It feels like a little bit of a forced march at times, and I'm sympathetic with that. I mean, you could spend an hour talking about knee pain easily by itself. But my main points here are to emphasize over and over plain films followed by more specific imaging modalities, and that each joint's a little different than the other joints. The knee joint is the same as the other joints in the injury, plain film first. So what are you going to see with plain films? You can see obvious fracture, like this case. Sometimes the orthopedic surgeon, as in the case of the shoulder joint or any other joint, can order CTs for fracture fragment configuration evaluation. In this case, the cross-sectional imaging marked C and D here shows you displacement of the fracture fragment, shows you the manifestations of the fracture, the intra-articular manifestations of the fracture, and the displacement of those fracture fragments to tell you what you need to do to reform the joint in the best, most anatomically congruent fashion to get the best long-term results for the patient. And that's why they use these CTs. They're trying to figure out how many fragments there are, where they are, what's displaced, what's not. This composite picture shows you the fracture, and then the CT, which was ordered by the orthopedic surgeon prior to instrumenting that fracture for repair. The other thing is, if you see a fracture on the plain film exam, you know that there's some high likelihood of a significant soft tissue injury that requires instrumentation, even if the fracture doesn't, then you get the MR. So in this case, A marks a fracture of the tibial plateau along the tibial eminences, and you know that there's some pretty significant soft tissue structures associated with the tibial eminences. It's not exactly where the cruciate ligaments come in, but it's close. Here the coronal MR in B shows you a fracture through the insertion side of the posterior cruciate ligament. Nicely seen here on a lateral study. The patient had intrinsic damage of the posterior cruciate and some avulsion injury of the insertion of the posterior cruciate ligament. Here's a composite showing all four pictures: tibial plateau fracture, bad cruciate ligament injury, and usually these do get surgical repair. Another verse of the same song is an MR for this injury, which you can see on this cross-sectional image. There's a fracture through the medial patella marked by the white arrow. On this twofer, you've got A, the plain film of the fracture, B, the MR showing you the much more extensive damage that's actually there, fracture through the medial patellar facet, joint diffusion, double arrow at the condylar contusion, and this is the archetypical lateral patellar dislocation. These are usually relocated by the time they come in, but can result in contusions of the medial patella and lateral femoral condyle, medial retinacular tears, and joint diffusions. Sometimes fragments in the joint which are loose, which need to be located and removed for good results. This is an additional couple of pictures. You see a big contusion of the lateral femoral condyle in C with the arrow on it. And then in D, remember the guy's on his back, so the sagittal pictures, the stuff toward the left of the picture will be up, and so the fluid level there is actually marrow fat and blood layering in the joint as the patient lays on his back in the MR scanner. Here's a composite picture of all four of those, and again, this is a case where plain film showed you an abnormality, that MR further shows you more bony abnormalities and the extent of soft tissue damage. Sometimes you won't even see a bony abnormality on the plain film. You'll just see a soft tissue abnormality like a large effusion. And then once you get the additional images here, B, you'll see at the location of the arrow on the MR that the anterior cruciate ligament is absent. And then you'll see also the pivot shift mechanism of injury causing contusions along the posterior lateral tibial plateau and the anterior or mid-femoral condyle. and also with a single arrow in C, the medial collateral ligament injury. So again, knee MR ubiquitously performed for knee injuries, traumatic injuries, because it shows you the extent of bone contusions, bone fractures, loose bodies in the joints, which ligaments are ruptured, what the pattern of fracture is, whether there's an accompanying meniscal tear, which sometimes is repaired prior to the ACL repair on a more urgent or emergent basis. So again, a composite picture of a lateral plain film showing an effusion only, and then all the soft tissue and bone contusion abnormalities you see on the MR associated with that. Plain films can also be just flat, solid, normal, like this guy who had pain after trauma, 62-year-old fellow, and the lateral did show you a joint effusion, no fracture. Here we see a pretty classic kind of ramified fracture there of the lateral tibial plateau. On the MR, C is a coronal T1 weighted image where the fat should be white, and it's got a lot of abnormal fat with obvious fracture lines through the trabeculae along the lateral tibial plateau, and then the sagittal image on the right shows you a tibial plateau fracture. Additional MR fractures here. Soft tissue injury. This is a MR only. I didn't show you the plain films, absolutely normal plain films. 48-year-old man had pain following trauma, and you see abnormal swelling and abnormal signal in the popliteus muscle, and this is a popliteal muscle tear. Here is a 68-year-old woman who had knee pain after trauma. She's got a tear of the dorsal root of her medial meniscus there at the single arrow, and a contusion of the lateral tibial plateau at the double arrow. So that takes us through acute injuries. How about chronic knee pain? Well, as in the other joints, plain film first, looking for osteoarthritis, looking for chondrocalcinosis, and then MR maybe after that. Plain film's classic features of osteoarthritis, again, joint narrowing, osteophytic spurring, subchondral sclerosis, subchondral cyst formation. Here you've got CPPD crystal deposition disease, classic findings, different preferential degenerative changes of the patellofemoral articulation, chondrocalcinosis preferentially of the fibrocartilage, some calcification of the suprapatellar recess. Now, MR, in the case of chronic pain, can show you meniscal tears, loose bodies, spontaneous osteonecrosis, symptomatic bipartite patella, kind of a miscellaneous. Typical meniscal tear will show discontinuity of the meniscus, as seen here in A and B at the arrow. Loose body within the joint, you'll see a joint effusion with something floating around and filling it up that shouldn't be here, as seen here, A and B at the arrow. Spontaneous osteonecrosis of the knee, which has the delightful acronym SPUNK, which shows you focal abnormal signal along the femoral condyle with that serpentine margin along it, just like avascular necrosis in the hip. There's a sagittal of the same imaging features, composite with coronal and sagittal images of the abnormal area of bone directly beneath the weight-bearing surface along the medial femoral condyle. Symptomatic bipartite patella. The usual bipartite patella on MR should not have increased signal on the T2 wave image along its margin. This can be a normal variant of bipartite patella. In this particular case, the patient was painful right at that location, and the MR showed abnormal increased uptake at the same location, so we had a diagnosis of symptomatic bipartite patella. And, surgical consultation, do they wire that, do they instrument it, do they remove the symptomatic loose piece, that's up to them. Composite picture of the MR and bone scan findings. And a cautionary note here with chronic knee pain, plain films first. Here's a case of CPPD where the MR was obtained first and read as abnormal menisci, likely chronic tear as the cause of pain, Here's the T2, and you can see there's abnormal sickle in the meniscus, and until you obtain the plain film and correlate that, you don't realize that all that abnormal signal is calcification. And really, it's chondrocalcinosis and CPPD crystal deposition disease causing the pain, not torn menisci. Here's a composite picture of the MR and the plain films, which were inappropriately obtained after the MR rather than before, leading to some misdirection on what the exact diagnosis was. All right, we're getting there. Ankle pain. Ankle pain. How about ankle pain? Well, you're going to get plain films first. Here we are with an anterior process fracture at the location of the arrow. Here's something that makes you shudder just to look at it. Fracture dislocation of the ankle, with the ankle going sideways relative to the tibia and fibula and all kinds of big nasty parts. This is going to go to the OR sooner than later. For negative plain films, you often will want to do an MR. A traumatized ankle can show you fractures and sprains, and you don't really need to do an MR for sprain, but you can differentiate a so-called regular ankle sprain involving the anterior talofibular and less frequently the calcaneofibular and posterior talofibular ligaments from a high ankle sprain, which involves a distal tib fib ligament. And that's important to know from a rehab sports training point of view, because the high ankle sprains require longer periods of rehabilitation before the patient's altogether better. So in this case, there's a 16-year-old who had pain following trauma, and you can see the normal intact syndesmotic connection, or the distal tib fib ligament spanning the anterior aspect of the ankle in A, there at the arrow. And then on the B one, you see the intact posterior talofibular ligament, and at the usual position of the anterior talofibular ligament, there's just ill-defined soft tissue density, and that's characteristic of a full-thickness anterior talofibular ligament injury. Here's a high ankle sprain, so you can see a lack of normal tissue between the distal tibia and fibula because there's a tear of the distal tib fib syndesmosis. In B, you've got a normal anterior talofibular ligament. So high sprain versus normal sprain, MR can sort that out for you. It'll also show you, as in this case, occult fractures in a 28-year-old who had pain following trauma in the lateral film. Didn't really show that fracture, but the MR did. The other issue is chronic pain in the ankle. You can see osteoarthritis, as in this 71-year-old man who had chronic ankle pain, joint narrowing, and osteophytic sprain, the usual findings of osteoarthritis. A rare condition called hypertrophic pulmonary osteoarthropathy. You can see periostitis along the distal tibia and fibula, and on the bone scan, diffuse abnormal increased activity all along these bones. This is a rare condition, and usually it's associated with some bad pulmonary condition, either tumor or chronic disease of the lungs. This particular patient was found to have a lung tumor on evaluation of the chest. Chronic ankle pain, you can do either CT or MR for subtalar coalition in those cases of chronic ankle pain or hindfoot pain or chronic painful flat foot. In this case, the lateral plain film shows some subtle increased density along the margin of the subtalar joint. You get the MR exam, and you can see really broad, wide, abnormal articulation between the talus and calcaneus, typical for tarsal coalition. Those bones should separate completely and have a normal joint between them. If they don't separate completely, that can represent an abnormal, does represent an abnormal articulation and the cause of pain in the flat foot. Here's another images C and D show you some more of the same, where C shows you an abnormally broad, wide, fused articulation between the talus and calcaneus, and D shows you some subcondylar marrow along those locations. Composite picture showing the plain film, subtle density, MR more conspicuous. CT is often done for this as well because it shows you the bones as well, and shows you how much bridging there is. There's a whole bunch of things in the hindfoot that you can see on MR that can be helpful in diagnosis, and we'll quickly go over those. Hindfoot sprain can cause that interval between the talus and calcaneus, which should be filled with fat, to be filled with soft tissue and rupture those tendons, rupture those interosseous ligaments there. If that's the case, patient can have chronic hindfoot pain. Tenosynovitis can occur. Here's a 50-year-old with a posterior tibial tendon split and tenosynovitis with fluid around the tendon, an abnormal configuration of the tendon. Achilles tendon tears could be partial or complete. MR can be helpful at showing you the location of the tear, size of the tear, size of the gap, which in some instances can kind of sort out whether you want to take them to surgical repair or not. Some institutions and locations, they favor ultrasound for that differentiation between complete and partial tear and size of the gap. Chronic ankle pain can be caused by loose bodies in the joint, as in the other joints we've looked at, as shown here. You can see retrocalcaneal bursitis on MR of the ankle, abnormal bone marrow signal with the black arrow, bursa with fluid in it at the white arrow. And finally, peroneus tendon split, as seen here on the cross-sectional image, with the white arrow showing the abnormally splayed portions of the peroneus brevis and the peroneus longus anteriorly translated up against the posterior aspect of the fibula in this patient with a chronic peroneus tendon split. Foot pain, we are down at the bottom of the body. Acute post-traumatic, same deal. You know, you're going to get plain films. Where's the fracture? Where's the dislocation? What do things look like on the plain films? And you're looking for the usual, fracture discontinuity. In this case, a 57-year-old man. Sometimes, this is an important thing not to miss. Fractures of the mid-forefoot junction involving the medial foot could be very subtle on plain films, and ligamentous injury in that location can be subtle. And what you want to do is get standing views and compare it with the other side, or go straight to a CT if you think there's an injury there. Undiagnosed injuries of the Lisfranc joint can cause chronic disability and are a source of a lot of lawsuits, frankly. So here you have on A, a little bit of a gap there that doesn't really belong there, and then on B you can see that little fracture fragment. There's a whole classification system of the degrees of fracture and the associated ligamentous injuries that occur at this particular location, but if you're suspicious that a patient has a fracture, standing weight bearing AP films of both feet to look side to side to see what the difference in that gap is, and a CT through that area are probably going to be friends. If you have a fracture and negative plain films, CT is probably as good as anything at working out whether there's an occult fracture that you're just not seeing on the plain film, as in this 22-year-old man where you had a fracture through the medial cuneiform seen on the CT where the arrow is. All right, what about chronic foot pain? Well, the podiatrist, you'll have a lot of films like this to look at if you're associated with any clinic that has a podiatrist in it, because they're taking films all the time to assess hallux, valgus, and cock-up toe deformities. The degree of subluxation, the degree of secondary degenerative change, the degree of deformity, whether to surgically intervene, what the things look like after the surgical intervention. These are the things that you're going to see a lot of. Less frequently, you'll be looking for osteonecrosis of the second metatarsal head. Chronic foot pain can also be caused by stress fractures. So in those cases, you're looking for periostitis along the metatarsal shaft, such as seen in this case of a 56-year-old who had foot pain after undertaking a new job and developed a stress fracture. Straightforward cause, degenerative change of the great toe metatarsal phalangeal joint with, as usual, joint narrowing, chondrocalcinosis, osteophytic spurring. And finally, you can see on plain films gout with soft tissue swelling, calcifications of the soft tissues, tophus in the soft tissues. Diabetes is an entire hour-long talk unto itself, but let me briefly say two different issues, one of which is Charcot joint, not particularly painful, swollen, associated with fat foot and deformity caused by denervation. The archetypical plain film findings will include a lot of debris and disorganized joint and displacement of the joint, flat foot, which is not particularly painful. On the other hand, diabetics are also prone to infection, as on this exam where the black arrow shows a destroyed metatarsal head, the white areas show, the white arrows show areas of periostitis, and there's obviously dislocation / subluxation of the number of joints and soft tissue swelling along with the infection there. MR is frequently done in these patients. Even if you know they have an infection, you want to know which bones, how far proximally in those bones the infection goes. It doesn't completely distinguish, of course, edema from infection, active infection, but the normal marrow, is normal, so you can, the surgeon's thinking, where can I resect to? Where do I stop resecting in order to get to normal, healthy bone so this patient can heal up? They've got awful circulation, the microcirculation's awful, they're diabetics, so you're going to have a problem there. Okay, that brings me to the summary. And again, there's a lot of joints in the body, but monoarthropathy can be a precursor of polyarthropathy. Always kind of keep that in the back of your mind, especially in the correct clinical circumstance of a 40-something-year-old woman who comes in with wrist pain for the first time. Is that rheumatoid arthritis? Does somebody have psoriatic arthritis? And is the monoarthropathy you're seeing part of polyarthropathy from gout or some other cause? And then finally, each and every joint in the body has a little bit different considerations, but usually, generally, acute trauma, plain films first, CT if you've got to know where the fracture fragments are at the discretion of the orthopedic surgeon, MR if the plain film's normal or abnormal in a fashion that you need to further evaluate, and you think there's occult bony injury that you're not seeing on plain film, or if there's bone injury you want to further characterize or see if there's associated soft tissue injury on the MR. Thanks for your time. That's a long lecture, and I hope you got something out of it. Next time you take care of someone with a bad joint, you'll know how to do it.